Good morning, everybody. I think we can start. My name is Galileo Disperati of Martel Innovate, greeting you from Switzerland today. We have a pretty full program today, and the webinar will be recorded and sent to the attendees. As a quick opening remark, there is a Q&A chat that you will find besides the webinar chat, where you can put down your questions for the Q&A session that will end today's agenda. Without further ado, I would like to leave the floor to Linda Henriksson from CAR Communications, which is covering the ONCOSCREEN side of things, to a short introduction, and we will also moderate the webinar. Thank you very much.
Perfect. So good morning, everyone, and welcome from my side as well. So my name is Linda Henriksson, and I am an EU project director here at CAR Communications, which is one of the ONCOSCREEN partner organizations, and I will be your moderator today. So we're hosting this important webinar today on the 20th of March in honor of the ongoing European Colorectal Cancer Awareness Month. And as you probably have seen, we have an interesting agenda ahead. Our speakers will explore the latest developments and raise awareness of recent advancements and next steps in colorectal cancer research, driven by these European initiatives. So without further ado, let's get started. I'm delighted to introduce ONCOSCREEN coordinator, Anaxagoras Fotopoulos, research and innovation manager at EXUS, to give us a few opening remarks. So, Mr. Fotopoulos, the floor is yours.
Thank you, Linda. I just wanted to thank both teams, from you, from CAR and Martel. I think you have done once again a great job here today for hosting this event. So moving ahead, I think something that at least the coordinators we say about this cluster, I will start with that. It's the first time that we see a cluster moving ahead, that we see projects truly collaborate each other, and I think we shouldn't miss this chance. I mean, for the benefit, let's say, not of just the consortium, but of everybody. I mean, we know, and you know how important is colorectal cancer and the overall research. The fact is that currently, early onset colorectal cancer is on the rise. And the thing is that we do not know why. We need to learn more and to know more. And I think into this, there is much room for improvement and a very big room for our projects to contribute. So today, we're having a very interesting, I would say very interesting topics to discuss, but I would like also to remind everyone to utilize this chance, I mean, for collaboration among the two projects. I think it's a unique opportunity. We go in parallel. We have started nearly at the same time. Of course, we have different timelines as projects. However, we have a common goal, I mean, in regards to colorectal cancer. So I think there are many areas where we can collaborate together. I mean, from understanding risk factors, this is a continuous process. It will not end at the end of both projects. It will continue thereafter. And I think jointly we can help into this. Also, we can help in the understanding of inequalities. I mean, why inequalities exist and happen, particularly in regards to CRC across different countries in Europe. I think we should, the most important thing for me is that we should join forces in regards to policy recommendations. So maybe this is something that that can happen towards the end of the projects when we are going to have results, but we cannot say that the one project will have different suggestions than the other, and both projects go into our policymakers and propose different things. We need to align ourselves for the benefit of the citizens, actually, and propose joint recommendations. I think this is a very big outcome that we should work and think together, I mean, into this, and especially for breaking silos in research, breaking obstacles that we see. I think it is very important, both projects, to conclude early on with some kind of a white paper on early findings, what we have found at this early stage, and this can map also the challenges that we face. I mean, about difficulties in protocols or in data or anything that we see, so that we can propose such things for change. So I see a great room for collaboration, I mean, in multiple areas, both in research, both in policymakers, both in contributing through open science and open data. I think, and this collaboration about joint communication and dissemination strategies needs to go in parallel, side by side, the two projects. I think we have a lot of to gain together. And for example, ONCOSCREEN currently runs a very nice initiative about creating an oncological living lab, obviously in CRC. And we're going to have some hackathons. So from our side, let's say we are going, Ivana from CAP Communications is going to send some link also in regards to those hackathons that you can disseminate in your network. Of course, for us, this was the first year that we prepare, and we are sure that the next year will be even bigger. So I think there is many areas where we can collaborate together. For me, as I ask my team and my project partners, is don't leave it at the meeting or at the webinar level. Make some actions. What is your expectation out of this? Be active, make questions, and take it to the next step. I mean, don't see it just as another project that will end, but see it as a very big opportunity. I mean, mission cancers are much strategic projects for European Commission. So they are really going to hear from us what we can do and what obstacles, the challenges we face, but also the highlights. They expect some highlights and some good stories from what we do. And I think this collaboration between the DIOPTRA and the ONCOSCREEN is one of those highlights. And I'm sure that we will continue to have this collaboration ahead with many great results. So wishing to both projects all the good. I mean, a nice start in this collaboration. I would like to give the floor to the next speaker, and thank you so much for being here, participating, and working towards finding solutions that can help, I mean, even towards saving some lives eventually, even if it is in the long term. I think this work is, this goal is above us, is above the projects, and I think we should be focused on that in order to contribute towards this. So, thank you.
Many thanks for that, Mr. Fotopoulos. Before we move on to the actual speaking slots, I was wondering, Jill Blocker from Martel, did you want to have some introductory words?
Oh, no, thank you. I think we covered it with Galileo, but I'm new at Martel. I'm supporting the project now, so I just wanted to thank everybody also for especially organizing it during this month of Colorectal Cancer Awareness Month. I think we have a lot to share and collaborate with. So yeah, thanks everybody for joining.
Great, thank you. So now let's move on to speaker, Professor Sisse Helle Njord from the University Hospital of Southern Denmark. She unfortunately couldn't be with us live today, but we'll still have the pleasure to have to listen to her on screen through a recorded presentation on colorectal cancer screening, current methods, and future prospects with biomarkers. So let's listen to this now. Thank you.
My name is Sisse Njord, and I'm professor at University Hospital of Southern Denmark. I'm going to talk about current methods and future prospects with biomarkers in colorectal cancer screening. As you can see from this figure, the chance of surviving a colorectal cancer diagnosis is heavily dependent on the stage at which the cancer is detected. On top of this, it is way more expensive to treat a stage 3 or 4 colorectal cancer than a stage 1 or 2 cancer. The overall aim of colorectal cancer screening is to find the colorectal cancer case at an earlier stage or already as precursors in order to increase survival and lower the costs for the healthcare system. As the risk of colorectal cancer increases by age, colorectal cancer is mostly offered to individuals above a certain age, for instance 50 years. One way of doing colorectal cancer screening is to offer all individuals above 50 years a colonoscopy, which is an examination of the inside of the colon and rectum. Possible outcomes of this colonoscopy is either that nothing was found, which means a normal colon and rectum, that non-advanced or advanced adenomas were detected, or that colorectal cancers were detected. Some European countries have colonoscopy screening either as an organized screening program where invitations are sent to the population. This is, for instance, the case in Poland and Germany. A screening program can also be opportunistic, where the population has the possibility to have a colonoscopy without symptoms. This is, for instance, the case in Austria and Greece. The problem of doing colonoscopy screening is that only a small proportion of the population gets this procedure when they are invited. Probably because having a colonoscopy means going through a bowel cleansing procedure that gives some discomfort or fear that the colonoscopy is painful. All 4 countries above have reported that only 10 to 25% of the population are up to date on the recommended colonoscopy screening. Other issues with colonoscopy screening is that it requires quite some colonoscopy capacity, which might not be available, and that colonoscopy is quite expensive for the healthcare system. Many European countries have therefore introduced fecal occult blood testing called FOBT test, where residents have to take a fecal test that is then examined for occult blood, and only those with a high hemoglobin level in the stool are then invited to have a colonoscopy. Even though FOBT test is non-invasive and way easier than colonoscopy, then in most European countries only about 60% do a FOBT test when invited. On top of this, more than 40% has no adenomas and colorectal cancers detected at the colonoscopy that follows an FOBT test with a high hemoglobin level. Blood-based biomarkers might therefore be a good alternative to FOBT test, as they might be better at predicting who should be invited to a colonoscopy, as they have a high risk of having colorectal cancer or advanced adenomas. Individuals might also participate more if they have to do a blood test instead of doing a fecal sample. There are quite some ongoing and previous projects that tries to find blood-based biomarkers that can predict who has advanced adenomas or colorectal cancer. One example is the endoscopy trial from Denmark, where they tested 9 cancer-associated blood-based biomarkers. and found that some of the biomarkers were quite good at detecting colorectal cancer, but none of the biomarkers detected advanced adenomas as well as an FOBT test. Their conclusion was therefore that more blood-based biomarkers need to be tested before this can be implemented in colorectal cancer screening programs. The overall conclusion from the ongoing trials is that identification of ideal biomarkers that can predict who is in need of a colonoscopy, are safe, cheap, and easy to measure remains a challenge. Thanks a lot for listening.
Thank you for that. We know that the audio level was not ideal, at an ideal level there. It will be adjusted in the recording, so hopefully you will hear it better then. If you have any questions on what Dr. Noor presented, you can still submit questions in writing and we can pass them on to her by email, so that's no problem. And now let's welcome our next speaker, who will be Dr. Yannis Papanikolaou from the Attikon University General Hospital in Greece. He will speak to us about unlocking the future of colorectal cancer screening, exploring colonoscopy, biomarkers, and triage strategies. Dr. Papanikolaou, the floor is yours.
Thank you. Thank you, and thank you for the kind invitation to participate in this meeting, especially now that we have the Cancer Awareness Month. It's a real privilege to be able to address the audience and to present some data about unlocking the future of colorectal cancer screening, exploring colonoscopy, biomarkers, and triage strategies. Actually, this is a very nice title, catchy title. It was created by artificial intelligence, generated by artificial intelligence, just to show where our future is pointing out to, and how useful AI will be in the future. So I have no relevant disclosures. And the epidemiological data about colorectal cancer are more or less known. It's the third most diagnosed cancer. It's the second leading cause of cancer-related deaths in the US. It has a lifetime risk of about 4%, and 53,000 are expected to die from CRC in 2024 in the US. The 5-year survival is good if the disease is localized, more than 90%, but is very poor if we have a metastatic disease already there, like it's about 14%. So as the Greek, the father of medicine, Hippocrates from the island of Kos said, it's better to prevent than to cure. And this is exactly what we're doing here. So CRC prevention can be focused on 3 areas. It's the primary CRC prevention, which aims to amend environmental factors. This is probably a little bit too harder than it sounds. So our efforts are mostly concentrated on secondary prevention, which means implementation of screening measures in the general population or high-risk groups to achieve prosymptomatic diagnosis or early diagnosis. And the third stage, tertiary prevention, which is to follow up and avoid recurrence post-therapy of colorectal cancer. The majority of CRC is sporadic, and it occurs when we have malignant transformation of a benign polyp, which we call adenomas. This has been described in the famous adenoma carcinoma sequence, where we have activation of proto-oncogenes and disactivation of tumor suppressing genes. And it's this famous adenoma carcinoma sequence that is supposedly lasts for 10 years. And this is very important for the ages that we set for our colorectal cancer screening because we notice a peak in CRC in the human populations after 60. So colorectal cancer screening in most countries starts when people are 50 years old. The goal is to find and to resect adenomatous polyps, and this has been shown to reduce CRC by 76 to 90%. This has been shown in the National Polyp Study, which was a famous study including many, many people in the US in the 1990s. So the population could be divided into average risk, which is the majority of patients, and high-risk population, which is about the 30% of the population. And that's when we speak about familial or personal history of CRC or adenoma, and some polyposis or non-polyposis syndromes, and long-lasting inflammatory bowel disease. And what are the methods that we use for our secondary CRC prevention, where we are focused at? It's colonoscopy, basically, but also other methods are there and can help us. And so colonoscopy is the basis, but we also can use sigmoidoscopy, which is a short colonoscopy. It covers about 1/3 of the entire colon. We have imaging tests that want to try to help, which is CT or MRI colonography. And we also have the stool tests that we referred to previously, the immune test, FIT, or the occult blood test, the FOBT, and for presence of blood in the stools, and blood tests, which are the biomarkers. So colonoscopy is our gold standard because you actually get to see the colon. It has a high sensitivity and a very high specificity for diagnosing polyps, adenomatous polyps, and cancers. It's a relatively safe technique, although its acceptance is pretty low. Cees previously mentioned that it was about 10%. It can be even lower in special populations. And of course, the costs are another issue because it's not a very cheap examination. This has to do with the country, of course. So as we said, secondary CRC prevention, screening colonoscopy should start at about 50 years in an average risk population. This has been now, due to early onset colorectal cancer, has been proposed to drop to 45. And in high-risk populations, it should start about 10 years earlier. We don't know when to stop screening. This has been, according to the American guidelines, maybe somewhere about in the 80s. I know many people that are about 80 years old and feel a lot younger. I'm not so sure that they would be happy to not have a colonoscopy in that age. So the situation in Europe was outlined by Cees. These are relatively new data from the United European Gastroenterology. 32 countries were surveyed. We have 7 opportunistic and 25 organized programs. Only one of them uses colonoscopy exclusively. The others are either stool tests, 16 of them, or 4 are combined stool tests, and then, if positive, then proceed to colonoscopy. Participation varies from 1%, as I said, to 73%, which can be high and is noted in organized primary care countries that have organized primary cares, for example, the Netherlands. And this is rather important, the uptake of the screening modalities, because as you can see, the more the modalities are accepted by the population, the lower, the biggest is the decrease of the colorectal cancer risk. So focusing on colonoscopy, we had our fairy tale that said that colonoscopy was perfect. Unfortunately, we discovered that that was not very true. We have interval carcinoma cases, which are carcinomas that occur even after a patient has undertaken colonoscopy, which are surprise carcinomas, let's say. And so we started talking about missed lesions and incomplete polypectomies. And it was shown in various studies in previous years, from 97 up to 2011, that in tandem colonoscopies, that means if I perform a colonoscopy me on a specific patient, and then I repeat it with the same examiner on the same patient, that we might have a miss rate of adenomas that might reach even 31%. These were mostly non-advanced adenomas, and that's a good thing, because if we missed advanced adenomas, that would be pretty dangerous, and that would render the examination rather not good. Also, another issue is that 24% of patients have an unpleasant experience, and that can be linked either to preparation or to pain during the examination. So, and why is it important that colonoscopy should be perfect? And it's very important when it's not imperfect, because as shown in this large randomized controlled trial published in 2010 in Lancet, including, as you see, hundreds of thousands of patients and controls, you see that even a sigmoidoscopy, that's the short version of the colonoscopy, the 1/3 of the colon, reduces CRC prevalence by 23% and mortality by 31%. So colonoscopy is a very useful tool when performed correctly. And so the research on colonoscopy has focused on finding markers that show that a colonoscopy is good, and that's ADR is the most relevant one, adenoma detection rate. That means in how many colonoscopies I find at least one adenoma. That means if I do 10 colonoscopies, screening colonoscopies, I should find at least one adenoma in at least 2.5 of these. That's the benchmark. And this was shown that it's very relevant because we had this publication by Michael Kaminsky in the New England Journal of Medicine that linked the higher the adenoma detection rate is, the lower is the risk of the patient to have cancer, colorectal cancer. On the other side, a 3% decreased risk of CRC it was noticed when we have a 1% increase of the ADR, of the adenoma detection rate. So it's a very important surrogate marker. And thus, colonoscopy quality is a very important factor. You see here the European Society of Gastrointestinal Endoscopy that has published guidelines about how a colonoscopy should be performed and what actually constitutes a good colonoscopy. And the reasons why colonoscopy is imperfect can be technical limitations like hidden mucosal flat lesions, or ineffective application of technology, suboptimal examination technique, ineffective polypectomy, and ineffective bowel preparation. These were presented in the American Congress in 2017. We have found solution for these problems. That's new technological devices, improvements of the colonoscopes. We've done some research in this area, in this field, in our department as well. We have some add-on devices that improve the visualization of the mucosa. And of course, as you can see here, this is NBI. It's a type of chromendoscopy that induces a learning effect, and people can recognize colorectal carcinoma or adenomatous polyps when this is used. It was one of my first publications on the field in 2007 in the journal Gut. Also, fused colonoscopy. This is a new colonoscope with a wider, which combines 3 cameras, and thus you can see more polyps as you have a larger field of view. This was published in Endoscopy in 2017 by our group. And also simple techniques like using water in order to wash the mucosa. This helps you visualize more mucosa. It helps patients experience less pain, and it has shown to increase adenoma detection rate. Also, as I said previously, here we have the technique of polypectomy. You see here the snare going into around a pedunculated polyp. Then you close the snare and you push the electricity button, which cuts the polyp, and it's retrieved for biopsy. But as I said, we have a problem, and the major problem is that people do not actually go to do colorectal cancer screening by colonoscopy. Here you see a small PubMed search that I performed some time ago, more than 1,500 results. describing the low participation in CRC screening by colonoscopy. So we have some other tools like stool tests, older ones and newer ones. We have the immunological test here with satisfactory for some carcinomas results, but not so satisfactory for adenomas, and especially non-advanced adenomas. And so we started looking for fecal DNA, that is DNA in the stool, and this produces some more satisfactory results, as published in the New England Journal of Medicine in 2014. However, even these tests, if they are given to the population, it has been shown that they don't actually make the population use them. Even these tests, because they include going to the toilet and gathering your stool, haven't been so widely accepted. This was shown in our hospital in this publication. We gave it for free. We offered it to the people working in the hospital, and they didn't complete the examinations, as you can see here. Low adherence, especially among doctors and nurses. Very disappointing. Here's a meta-analysis by Cesare Hassan published in 2012, 14 studies with almost 200,000 subjects. It shows that adherence is less for endoscopy, more with fecal tests, but detection of advanced neoplasia is more effective when endoscopy is the screening test. Radiology techniques, virtual colonoscopy, including CT, virtual CT or MRI, have been used. CT has radiation. They both need preparation, which is one major obstacle for patients to comply to screening. So they have not moved so much forward. We're waiting for prepless variations of these techniques. And biomarkers is the next step. As you can see here, this is a publication 2013 in Gut with almost 8,000 patients from the USA and Germany, which showed satisfactory results for advanced cancers, but not so satisfactory, I would say, for previous and early stages, which are actually the focus of our research. And they were negative for adenomas. So I'm not so sure that this was a very good test. 10 days ago in the New England Journal of Medicine, a new blood test was introduced, as you can see here, in a paper published that included 7,861 patients and showed very nice results in terms of sensitivity for CRC, specificity for advanced neoplasia, but pretty low for sensitivity for advanced preneoplastic lesions. So the problem remains, and our answer here in DIOPTRA, in our proposal here in our working group with DIOPTRA, is as follows. We aim to introduce a frontline clinical decision support tool that will consider risk factors and protein biomarkers to try to pinpoint individuals at high risk for CRC incidence. And maybe this could be used as a triage test in order to persuade these people to go and have their colonoscopy performed in order to find the adenomatous polyps or the early cancers and to treat them. As you can see, we combine acquisition of tissue and blood samples in the first stage. Then in the second stage, we will validate our findings only with blood and after colonoscopies are performed. These things will be shown further on by Zeshen Yan, who is following. And we have we gather other data, medical and behavioral, which combined with which will be used by artificial intelligence in order to generate a profile of people who are at high risk of developing adenomatous polyps, advanced adenomatous polyps, and colorectal cancer in order to persuade them to go and have their colonoscopy for screening. As you can see here, our expected outcomes is to find a set of prognostic proteins, to set key risk factors, and to develop this mobile app in order to find personalized behavioral factors that can be changed, that are modifiable, and we could persuade people to modify these risk factors. We aim to find a CRC screening tool via standard blood work, maybe boost participation rates, bypass age thresholds. You see, Mr. Fotopoulos previously mentioned early onset colorectal cancer, and this could be an answer to this, and to develop lifestyle-based screening. Here's the consortium, many clinical partners, as you can see here, throughout Europe, and other partners, data providers, biological data analysis, our partner Protavio, who is responsible of the development of these biomarkers, technical partners, legal partners, dissemination, standardization, and policymaking. So we're a group that's cooperating nicely. And our participation from the Atikon University Hospital of the National University of Athens is mostly in the retrospective data acquisition, the prospective data acquisition, and finding, as you can see here, the discovery phase, that is to develop, to find these potential biomarkers in the discovery phase, and to try to develop out of 4,000 protein targets, to find those that are more sensitive and those that can create and correspond to a model, to a model of a patient that is in high risk of CRC development. So this is actually a truly interdisciplinary research between engineering, computer science, biology, and medicine, which combines proteomics, transcriptomics, and wishes to develop network-based target and biomarker discovery for personalized medicine, thus translating research to human health. So in order to conclude, we have CRC screening. Every test, here we have an example, colonoscopy, is important factors of this test is its accuracy, its uptake, and its costs, which are influenced by the actual costs and the political factors. The accuracy is influenced by type of studies and study quality. And all this results to an outcome, which in our case is the desirable outcome of lowering of CRC incidence and mortality. This also has to do with the way the quality of the test is performed and the adherence to follow-up by the population. Our current situation seems like this and not exactly so nice like this, but we must say that CRC screening has been proven to be beneficial. CRC screening is the uptake is higher when fecal tests are used. The yield is higher with endoscopy, that is the yield of adenomatous polyps or CRC. So the incentives are with moderate effects. So that means that there is need and most of all room for sensitive biomarkers, and that's what we're trying to develop here with our project DIOPTRA. The choice depends on is also a political issue. It depends on resources and costs. And the outcome assessment should be performed by randomized controlled trials, but also in real-life studies. So the best test is the one that gets actually done. And I would like to thank you from this point. Thank you very much.
Thank you very much, Dr. Papanicolaou. That was very interesting. We'll certainly stay tuned for the developments in the DIOPTRA project, and lots of statistics and interesting bits of information there. Moving on then to our next speaker, Jeshen Chung, project manager at CHU, the Centre Hospitalier Universitaire de Liège, His presentation will focus on the DIOPTRA project and specifically on the collective effort of new biomarkers discovery for colorectal cancer screening, colorectal cancer early screening and beyond. So the floor is yours, Mr. Jung.
Thank you, Linda. Hello, everybody. I'm Justin Jiang. I'm from University Hospital Center of Liège, here located in Belgium. So today, just to give a very short overview of DIOPTRA project. And of course, I think that you already heard that what Dr. Papanicolaou has presented a little bit, what is the scientific rationale about our project, the DIOPTRA. Galileo, could you please go to the next slide? Thank you very much. So it's DIOPTRA is a European funded project on mission of cancer that lasts for 4 years. Currently now we are in month 15 and it's a 13.6 million euro project with 28 EU partners, as what Yanis have been showed to you. And with within this project, we have 9 clinical partners to collaborate on the elicitation of the studies. Next slide, please. So here just wanted to outline a bit all the strength that we have for this ongoing project. Until now, we have a very large retrospective data source, more than 50,000 raw EHR, the electronic health records that will be provided to the AI model after for analysis. And during the first phase of the project, we already developed through clinical requirements to the end to produce a data template with more than 250 primary variables that will be recorded from the patient's records. And we have also a very large geographic representation with 8 EU countries. And the new biomarker discovery for CRC early screening and onset with the proteomic methods called multiplex that will have a very high robustness when we will use 3000 protein library. This is a very big protein library for biomarkers, and with ELIS methods that could give a very high quantification specification. So we used also, as mentioned by Yanis, that the pair issue blood samples will be used in order to give a higher AI model mathematical explainability. And for the AI models that will be analyzed here in this project, we will examine multiple and use multiple machine learning and deep learning models and view through a prospective study recruitment validation. And lastly, the DIOPTRA mobile application will assist in the CRC screening and prevention. So after this, I will just simply present a little bit about the DIOPTRA clinical study calendar. Next slide, please. So first we have a retrospective EHR recruiting period with a discovery study implemented within that we will require all the electronic health records and also for the paired tissue and blood sample. Then from end of last year, we already began our prospective study that actually started this January 2024, that will last until almost end of June on 2026, that where we have a mobile application usage in the follow-up study with 1 year follow-up. Within that, the project will generate, next slide, please, will generate different data from different study and through clinical requirements, and also that at with all the ethical requirements that are needed for this project. And then from this data, the next step is to generate, of course, very interesting biomarker features from there, and also a risk factors analysis will be performed to in order to generate screening and risk model, and with the mobile models in the mobile application. Sorry. This will be used to do also the validation about all the modules that in the mobile for health literacy model for the improvement in the lifetime course during using this application, etc. And all the models will be validated during the prospective study at the end. Next step, please. So now at the current state, I wanted to show that what the efforts that put into this project and what are the current status of this project. The studies are progressing very well, and we already close to the goal and to the end for the first discovery study and the retrospective data collecting phase of DIOPTRA. And we already estimated that we reached the goal, of course, for our retrospective EHRs, and probably we will have more than 10 times of the data for a better understanding of the disease process. And also we begin already the prospective enrollment from this January to collect more data for the model refinement and also further validation. Next slide, please. And we just here wanted to mention about our main goals in DIOPTRA and also for the future impacts. So we wanted to, at the end, to propose a faster, earlier, personalized, accessible, and affordable screening methods through blood biomarkers. And this will be also used to develop the practical tools like DIOPTRA mobile application for the general population use and also for the health professionals. And of course, that DIOPTRA wanted to have a more longer contribution for the long-term mission on cancer currently in EU, and especially in the prevention screening of CRCs. And we hope that this project in the future could have some more practical impacts from the public health healthcare side for the policy side. And of course, we wanted to propose is a much cheaper option and much usable and acceptable screening methods for the CRC screening. And at the same time, of course, that we all know that from the discovery study, we will probably have very interesting protein networks that will be analyzed and shown. And this could help us, of course, to advance in the CRC basics research part to understand the molecular mechanism of the early onset of CRC that is still unclear to this day, and thus to provide some more possibilities in the future in order to better understand CRC, to better categorize CRC, and to better screening CRC in the future. And this brings some very possible good impact also on the society. And of course, that will help more people in the need that will contribute, of course, of this project in healthcare economy. And this is all the partners that involved in DIOPTRA on the next slide. And really wanted to ask clinical coordinators of DIOPTRA. We really wanted to thank them all for their current contribution to this project. And thank you for your attention.
Many thanks for that, Christian and Karen. As usual, if you have any questions, don't forget to pop them in the Q&A box there, either now or when you think of them later. So thanks. Our next speaker then is research professor David Rios from the Institute of Mathematical Sciences at the Spanish National Research Council, who will be presenting on the topic predictive model for colorectal cancer, risk mapping and screening support. The floor is yours, Professor Rios.
Thanks, Linda. So good morning, everybody. And we're going to talk about, some aspects of ONCOSCREEN. They were introduced by ANAX, and at large, they coincide with DIOPTRA. So as ANAX said, there's lots of opportunities for cooperation. Next slide, please. Could you move to the next slide, please? Yeah. So it has several work packages, the ONCOSCREEN, but we are mostly supporting what it would be the adoption of the solutions that ONCOSCREEN is going to provide. So Alex mentioned that we are mostly following new screening devices in 4 directions, but then we need to first of all evaluate, assess it, check it whether it's affordable, etc. Specifically comparing it with the standard of care. That's the task 6.1. And the other task that we are supporting is innovative financial schemes. Both teams already mentioned the low uptake of current CRC screen strategies. And the idea would be, how can we support to enhance such uptake? Next screen. So I'm going to explain a little bit what we have already done. The first one is basically a support stage, and what we are developing is a Bayesian network to try to predict colorectal cancer. This is done actually from 2 sources. The first is lots of extensive expert information that we have captured from the team, from the ONCOSCREEN team, and from the open open literature, and we also used ChatGPT, etc., to make the kind of search. That knowledge was built into a sort of first network to try to forecast CRC. Then we completed it, or we enhanced that network with extensive data from about 2 million records that we have from previous studies. And then we have used this for 2 cases, 2 use cases mostly, which will be useful in later times. The first one is risk mapping, trying to map, given some factors that we are interested on, what are the sort of worst or biggest population at risk. And the second one, which was also mentioned, is try to determine influential variables. But this has other use cases. For example, your risk mapping, which is other teams at ONCOSCREEN are doing. It can be used to generate synthetic data, which could be useful. Of course, it could be used for classification purposes. And what is most important for us, this is as I said, a support stage, is as a basic for screening design. Next slide, please. So basically, this is the initial network based on the expert knowledge. Basically, green refers to non-modifiable factors, red or pink to modifiable. Blue ones are medical conditions, and CRC is the target variable. So basically, this tries to reflect in somehow a causal manner what influence what, based on expert knowledge on the literature and so on. Next slide, please. And this is complemented with the red arrows with the data. So that's the sort of predictive model that we are going to use. These might be completed with other variables that are going to be connected through ONCOSCREEN, but that's the current version that we have. at the moment. And with this, we can make quite a few useful things. Next slide, please. The first one is on the left, the kind of risk map that we do. For example, this is trying to reflect for men, taking into account the body mass index and the age, comparing these two things. What is the sort of more population at risk? In this case, red is worse, blue, dark blue is better. The size of the squares, of the little squares, represent the population at the size of that population, and with this we can get good ideas, good hints, etc. There's numbers, but we don't need. And on the right, we get sort of based on that the type of influential factors, the most influential factors. You can see the usual ones: age, diabetes, etc., etc. Next slide, please. So this is, as I said, for us, this is already quite useful, but this is a basis to assess the screening strategies. Mostly the screening strategies that are going to be developed by ONCOSCREEN and possibly those by DIOPTRA. So for this, we use, we think screening as a decision process. So what should we, how should we screen somebody with certain features, certain population features? So, but what we are doing is given the current screening devices or technologies, what would be the optimal screening strategy for one person? So we assume in the model, we assume only what is the easy information available when the sign-in screening and data from our Bayesian network and other published sources. Next slide, please. So this is the kind of model that we're going to use. On the top right is the network, that our previous network, but you can see the sequence, the decisions that we need to make to what type of screening method. Are we doing colonoscopy? And then you can see how we evaluate based on the complications that were already mentioned, on the information, the value provided by the screen, on the coloscopy, the costs, and the comfort. And then we integrate this in a utility model. So the basic idea is basically one person arrives with a certain age, sex, etc., etc. What would be the screening and colonoscopy strategy to deliver to that person? Next screen. So we are completing the preference model, and then the idea would be to compare screening strategies in various countries. What is the best one? You saw we were shown that strategies differ country by country. What would be the impact of budget available, let's say, for Spain? I mean, it has a budget, and therefore how this impacts the screening strategy as a consequence. And quite importantly, the sort of this model would be ready for the new ONCOSCREEN screen methods that are going to devise. And also finally, to mention that the scheme of incentives that we want that ONCOSCREEN is going to develop will be incorporated into that network eventually when we have designed it. And I guess that's it. Thank you again, and well, we are happy to collaborate and discuss whatever. Thank you.
Many thanks, Professor Rios, for those interesting insights. Now we will shift the focus slightly to the needs of patients. We have Professor Dr. Cristina Stefan here from Bucharest Oncological Institute, and she will speak to us about addressing the needs of patients with colorectal cancer, equity and progress. Professor Dr. Stefan, the floor is yours. Just to say, would you like to, yes, you can share your own screen there. Perfect, thank you.
All right.
You're
so
mute.
I suppose you can hear me now?
Yep.
All right. So thank you so much. I'm really excited to be here and really for organizing such a insightful webinar. And from my side, the title that I did choose for today was really a rather different than presenting the project. And I decided to address the needs of the patients with colorectal cancer, but from a different angle, and that is related to equity and progress. I'm a professor in medicine and global health. I'm the president of the Medical Education Research and Innovation Center. But for this project, ONCOSCREEN, I offer the scientific expertise and technical expertise to the Institute of Oncology in Bucharest. So why did I decide to choose, let's see if that goes further. So why did I decide to talk about that? Because talking about ONCOSCREEN might take me a few hours because it's really an innovative project. It is a comprehensive project. There are many countries, many centers participating, objectives. It's extremely ambitious with really very powerful outcomes. And I thought that I would not make justice for the 10 minutes which I am allowed really to discuss. And then because I also understood that the focus should be on the colorectal cancer, and especially because this webinar takes place today, 20th of March, and today, I mean this month, March, is the Colorectal Cancer Awareness Month. However, I would like also to challenge that despite the fact that we dedicated a month for colorectal cancer awareness, I would suggest, or I would encourage everyone to consider each and every month of the year a colorectal cancer awareness, as we are all aware that the incidence of colorectal cancer is on increase, the prevalence is high, and it is a disease where we could really focus and obtain some spectacular results. It was interesting that while I was thinking what should I bring to the table and how should I engage with the audience, I thought I found this to-do list where someone wrote schedule a colonoscopy. And without really trying to reduce by any way the significance of a colonoscopy, I would also encourage you to have a to-do list on my left, as you can see it on the left. And then on that to-do list, us together in a collaborative way to look for more innovation, for more novel and more precise and affordable risk-based screening methods, obviously, which will translate into viable policy pathways, which in a single statement defines actually ONCOSCREEN, the project that we are participating. And again, I'm sure that everybody should be aware by now the fact that it is a project financed by the European Union. Everybody knows about Horizon Europe and about Cancer Mission, and also that ONCOSCREEN is a European shield against the colorectal cancer, where innovation really plays the important role. I think you know my presentation, despite the fact that I did not talk to my previous colleagues, complements rather well, because we heard about survival rates, we heard about epidemiology data. So definitely focusing on the facts should be the starting point. And I think, you know, everyone knows by now that colorectal cancer affects all races, genders, ethnicity, that a very high number of people, a high percentage of people have no family history of CRC. And I would like also to underline two of the previous statements made during the webinar. One of them was related to the survival rate, which is absolutely correct. The earlier that one could detect colorectal cancer, the better the chance of survival, no doubt about that. But I would add something that is just as important or even more significant, the fact that the geography, the location where you live plays a huge role into the survival of these colorectal cancer patients. And from here, I will talk a little bit, I'll touch on the equity. So it is essential because despite the fact that we live, all of us in Europe, there are huge disparities, huge inequalities between countries. And we used to classify them as countries, European countries on the Western side and the Eastern European side, where again, patients do not have access on the same way to treatment, to screening, to the same outcomes. That would be the first comment. And the second thing is, again, about young population. It's on the rise in people 45 to 49. I am extremely pleased to the fact that ONCOSCREEN looks again at the risk factors and looks at the screening and the risk stratification. This is why, for example, I encourage my students not to use old papers and old articles like 2010, 2012, because behavior is changing, progress is made, like every single day something new appears. And again, we talked about colorectal cancer in people above 50. We talk now about patients above 80, perhaps nothing uncommon, but it is more and more that we see colorectal cancer in people in their 30s. And again, I had a chance to work in many, many, many countries, in Africa as well. And this is on the rise, even if we don't understand it very well. All right, mission on cancer. Again, I think everyone is aware about the challenges and about the goal and also the mission objectives with the concrete actions. And here is ONCOSCREEN. And again, as I said, I will not go through all the objectives, but really it's about innovation. It's really about new methods and technology for cancer screening and early detection. And I would like you to really focus on the breakthrough and also on the low cost. So again, we talk about bridging between patients on one side, and I would like to change the patients into healthy citizens, because this is what is all about. Healthy citizens, that they will not become advanced patients, or they could perhaps change and go into primary prevention and prevent, or if not, really screening, which could allow them and us as clinicians to diagnose as soon as possible and having the best outcome. So the patients on one side, healthy citizens, the clinicians on the other side, and obviously the policy makers, which need to work all together. So I thought, okay, let me talk or let me touch on the patient needs in CRC. And again, I mean, it's a complex discussion and 10 minutes would not allow me to do that. But obviously you see listed here some of the needs, such as, information and education, long-term survivorship care, pain management, and so on. But if I could pick up any of those, again, and the list is rather restrictive, I would say that progress in screening was listed one of the most important needs of, I would say, healthy citizen versus patients. Something that I'm extremely passionate about is about equity, because the place where you are born, the place where you live, should not dictate the outcome of the disease. And again, I would say access to screening and prevention with a number of other subtitles, such as health literacy and patient education, policy and advocacy. And during ONCOSCREEN, from our point of view, we are extremely happy to be part of the clinical trials that will allow us to see perhaps the screening of the patients of colorectal cancer rather different. And one of the previous speaker was referring to low participation. At one stage, it was 10 to 25, organized versus opportunistic. And I will also share one or two slides with data in Romania, again, with a high incidence of cancer, with a high percentage of deaths. And I need to draw your attention that these are just estimates, as we do not have a registry, so we are not even aware, so the impact could be even higher. And talking about equity is again comparing to the EU average. Looking between last 10 years, again, we don't have new data. Looking at the risk factors and prevention policy, again, gender and social inequalities, which are really marked the need for more prevention efforts. And here on this slide, colorectal cancer screening, percentage of the population between 50 to 74, again, pending between low income and high income, and looking at the EU average. And the cancer mortality, which remains rather high. Since everyone was talking about this ChatGPT, of course, we did the same exercise and we trained a model in a conversational way and asked a few questions, follow-up questions, admitting the mistake, challenging incorrect premises, and then, of course, rejecting inappropriate requests. And we asked, what would be the most innovative research topics if we could develop new methods and technologies for colorectal cancer screening and early detection? And of course, I'm not going to read or go through all the slides, but I thought it was really interesting about the artificial intelligence, which is really becomes more and more used, about the biomarkers, about the liquid biopsy for colorectal cancer, about the smart capsule for colorectal cancer screening. And I think most of you are aware about this small pill-like device, which contains sensors, about biomarkers that you have heard before, about optical imaging, about augmented reality, about breath analysis for colorectal cancer, about nanosensors, about the digital health tools. So why did I decide to run this test, which was done actually a while ago, was that basically the most innovative approaches that one could think in terms of really trying to increase screening, trying to increase accessibility, are found in the project which is run currently and on which we are participating. I'm referring also to the colonoscopy as the fairy tale, the perfect story, which of course is not perfect, as we have heard, but again is that huge difference that colonoscopy is still not accepted by the population for several reasons. So looking for a non-invasive test tools which could really direct to the colonoscopy for those who obviously need colonoscopy, but with the same aim or desire to pick up colorectal cancer as soon as possible and having the best outcome. Of course, it's also a project where an ambitious project where more than 4,000 or more than 5,000 patients will be recruited. You have a list of the countries which are participating, but really what I think it makes it special is the desire of really working together, having different partners, 39 partners, multidisciplinary, having all type of skills, technical people, scientific people, patients, users, citizens, with the same objective of really innovating and making a difference in the patients, in the life of the patients or healthy citizens with colorectal cancer. And I would end by saying that every month is a colorectal cancer or should be a colorectal cancer awareness month. And we should really intensify all our efforts in order to come up with the most innovative approaches and with the most impactful way to really stop or have the best outcome for this disease. Thank you for listening to me.
Thank you so much, Professor Stefan, for giving us all that food for thought there. Now we have one presentation left, so we will directly move on to that. Last but certainly not least, we have Sofia Coelho Silva, Head of Communication at Europa Colon Portugal. And she will be talking us through some of the awareness, colorectal cancer awareness initiatives. So the floor is yours.
Good morning, everyone. Hi, so you can see my screen?
We can, yes.
Yeah, okay, thank you. Okay, so I brought these slides about Europacol in Portugal so that everyone knows a bit of our work. So it's a patient group association. It exists now for about 17 years. We have a total of 100 associates, and we advocate, we try to better understand colorectal cancer. We try to teach people about this disease because it's a very huge and bad disease in our country. So we try to promote preventive attitudes, improve the quality of life of patients. We also support survivors, family members, caregivers also because they suffer from with the disease also. And we try our best to decrease the numbers of digestive cancers and colorectal cancer. So we have a lot of projects during all year. So awareness campaigns, support programs for informal caregivers, home support for patients. And also we focus on younger population because we see the rise on younger patients, unfortunately. So we have a school education project that focus on nutrition and the importance of a healthy nutrition to prevent this disease. We have this program, which is very good. So we have an helpline for patients, for families, for survivors. Every year we organize an opportunistic screening, psychology consultations, nutrition consultations, which is very important, specifically for patients and survivors. A second medical opinion, which is also very important, home support, for instance. So we have a lot of support services, which are very important to people, and we try to raise the awareness of this. So in Portugal, we don't have an adequate colorectal cancer prevention policy. So this unfortunately leads to a non-adherence to screening. We have about 4,000 deaths per year and 11,000 new cases. So it's very important for us to have a new screening method because currently the ones that we have are still not working. Last year, we organized a focus group with about 15 people, and we learned and also confirmed what we already knew. So no base population screening in our country. So we heard about equity. Professor Christina was talking about this. So the access throughout our country is very different. Unfortunately, in Lisbon, in Oporto, which is the north of the country, it's very, very different. If you come from a minority community, you don't have the same access regarding a person that lives in the city, for instance. We also discovered about a lot of emotional and psychological barriers. So people are very scared of making a colonoscopy. They think, some of them told us, so if I do this, I'm able to die because it's a very dangerous exam. So this is a very strong barrier, unfortunately. They are ashamed to talk about this part of the body, and they also have some inertia. So I don't want to go to the doctor, I don't need this, so this is also a barrier. The results accuracy, so we still have to deal with a lot of false positives and negatives also. So this is a preoccupation for us. Family physicians, so we try to work with family doctors because they still don't value enough the symptoms. And also they don't know how to communicate with patients very well through a simple language, I would say. So disadvantaged population, so minority communities don't have family doctors. So in these 15 people that we have in the focus group, only one had family doctor. They don't have money for transportation. So even the ones that had to go to the hospital for treatments, they couldn't go every month. They have to choose. They don't have access to healthcare. They don't have money to go to the pharmacy. So it's very complicated. Also, the language is a barrier. So the language, if it is very technical, very hermetic, people don't understand. So we have to have a simple language to increase literacy, especially in the healthcare area. We have to have a good communication plan. So we learn definitely that to communicate and the proximity with these people, it's very important, so they can understand what is the disease, what are the risk factors, what is the benefits of me doing the screening to save my life, for instance. What I was saying about colonoscopy, so a very invasive exam. So people, they don't want to do it. So they are very scared and discourage people to do it. So we try to talk about the symptoms. It's very important because people, they don't know if you have a change in bowel habits, if you have a blood loss, if you have abdominal pain. So we try to focus on this so they can learn, so they can think, okay, I'm having this, maybe I should talk with my doctor. And also about the risk factors. So if I had already a polyp, I had an exam and I have a polyp. So, okay, this is a risk factor for me. If I'm obese, if I don't eat well, if I smoke, if I drink alcohol a lot. So this is a risk factor, and we try to teach people about this. And how can I prevent? So we talk about screening. Get screened, screen. Don't have fear of this. Talk to your doctor. So we have to reduce alcohol and tobacco consumption. We have to reduce the consumption of red meats and processed foods because this is terrible. We have to reduce fried, greasy food, increase the consumption of fruits. It's very difficult for people to do this. Exercise, so we all know this, but we don't do it. So, but we keep pushing. So it's for all of this, we try to elaborate a communication plan. We have to raise awareness still. We intend to educate and raise awareness for the people, encourage people to adopt healthy habits, citizen engagement, so informing others. Also, we have an active roles, push policymakers for measures, learn, talk to my father, go screening, talk to my grandfather, and increase this participation and acceptance of a screening program. So our target audience is about 50 to 74 years old. And also on social media, we are talking to younger patients because it's important. It's on the rise, unfortunately. So in March, which is the Colorectal Awareness Month, so we have a program in social media. We're trying to build media relations, so have TV shows, newspaper interviews. You're going to see on the next slides, articles, a press release, so a lifted content we're also developing. In April, we're going to have 2 awareness lectures. One already has a date, is on 27 April. A news story in a very large scale daily newspaper, also on an online health newspaper. And we are speaking with influencers. So if we can see that we can approach the younger population, it would be important. In September, we are preparing a nationwide screening with a group of 100 pharmacies. And then all year, of course, we try to increase awareness, talk to the family physicians for screening and symptoms. It's very important so they can value this. So in here you have an example of our social media posts and stories that we shared with the partners. It's important, everyone can use it and edit and put it in their own language. So we made a post plan that we shared with everyone. And also a press release that we're using on one-on-one negotiations with the journalists. So if we can see, we can see here we have already an interview with the Público. This is a daily newspaper. We have an interview with Anaxagoras, the president of Europocolon. We have also the director of Department of EPO, which is Professor Mário Diniz Ribeiro, and also with the Minho University interview. And we have also a News Pharma interview about ONCOSCREEN. So we are talking to journalists about this new method, what we're researching, what we need for the population. So patient needs that can be addressed, and also the rise on younger population. We are also developing leaflets for distribution. So in every action, lecture, school program that we go, so we can also have explaining what are the symptoms, what are the risk factors, what are the steps to decrease the risk, what people can do, and the importance of the screening. We also have an article I invite you to read on ONCOSCREEN about the colorectal cancer in Europe. It is on the rise, unfortunately. So in April, we're going to have an awareness lecture, 2 lectures for about 150 people. So we're going to talk about the numbers of this disease, and we're going to ask the participants to get screened and to get involved in their own health and the communication materials that are needed we're working on this. So we also want to talk with influencers so they can help us to disseminate the message, especially amongst younger populations. So we're trying to build a campaign specifically for the ones that talk about healthy lifestyle, nutrition, wellness. So if we can see if we can amplify our message. We also are on the build of educational infographics, because videos and infographics are easy to understand and to share. So we are working on this, and also ebooks. We're going to have some patient stories. For instance, in Europocolon, we have a patient, I remember now, he has 47 years old, and he has colorectal cancer. So younger patients, unfortunately, we have patients that we have in Europocolon with this disease. And in September, so we're going to have a national-wide screening in about 100 pharmacies throughout the country. We have an informed consent, a specifically built questionnaire for the pharmacists to have to do the population, a project manual. So we're going to have also a webinar, kind of a e-learning for pharmacists, so they can know more about this disease, what they can ask, and what data do we want to collect. We have communication materials, so MUPI, social media visuals, newsletters. We're going to participate in this pharmacy group magazine, which is Revista H, and have a social media paid campaign, because advertising in social media, it's also important to increase our reach. And so this is it. Thank you very much.
Thank you so much, Silva, for that. Very good to end with this kind of awareness raising. All those initiatives are so impactful. That is great. Thank you. Now, I can see that, so we've gone through all the presentations and we've used up all the time we have. I'm just checking the Q&A box here. We don't have any questions asked at the moment, but we do want to allow discussion and dialogue. So if you do come up with questions afterwards, don't hesitate to get in touch, and we will pass on the questions to the relevant speakers, or and get back to you then in writing, if that's okay. So, and we don't want to keep you too longer than the allocated time. So with that, we would like to thank all our speakers, incredible speakers today, for sharing some of the expertise you have, some of the advancements and challenges in this complex field. Also, special thanks to our attendees today. And I will pass on to my colleagues on the DIOPTRA side.
Hello, I think you can hear me and see me now. Yeah, just from our side, I would like to thank all the participants and all the panelists for sticking to the timing as much as possible and for delivering all this great amount of information. I think it was very informative hour and a half.
Thanks so much. Take care.
Thank you.
Bye.